No, it's okay right now.
Thank you so much, Amy, for the kind introduction. First of all, good morning to my colleagues in United States and good afternoon to my friends and colleagues back home in Iran. I should thank ISN and also Iranian Society of Nephrology, especially Dr. Savage and Dr. Osare for this collaboration with ASON. Also, a special thanks to Dr. Amy Yah and Dr. Harish Sitabadi, fantastic co-educational chairs of ASON for their great work. A few months ago, we had a similar webinar for Indian Society of Nephrology that was very well attended, and my friend, Dr. Kenar Javari, he had introduction talk there and he did a great job. So I thought I'm just going to follow his line of talk. I'm hoping that I can, give you some information about the history of onconephrology, what onconephrology is all about. Then we are going to learn from our speakers. So I would like to share my screen. Amy, could you let me share my screen?
You should be allowed to.
Okay, now it's good.
Okay.
All right. Where was my presentation? Do you see my screen?
Yep, that looks great.
Very good.
Perfect.
We all know that over the past couple of decades, there has been significant change and progress in the field of oncology. Nowadays, there are more cancer survivals compared to what that was 20, 30 years ago. There are also many new treatments available, and every day we hear new treatment every day. Every week, new medication is out there, which we didn't know about. And this is, because of hard work of our oncology colleagues, and thanks to them. Of course, these new treatments are not free of side effects, and renal side effects are one of the issues which, as a nephrologist, we are encountered with. So, out of all side effects, probably acute kidney injury is one of the major ones. We can have acute kidney injury in onconephrology with similar etiology to other issues, right? But there are some aspects of acute kidney injury which is very unique in onconephrology, and in onconephrology community, we are trying to help our oncologists to help and solve these problems. What are the common causes of acute kidney injury? Of course, I'm not going to go through detail of these. I just want to, give you some highlights and idea what onconephrology is all about. So, tumor lysis syndrome. We can have thrombotic microangiopathy. There are drug-associated nephropathy. This could be because of conventional chemotherapy agents, or this could be because of newer treatments, targeted therapies, immune therapies. You could have urinary tract obstruction. We are going to see light chain cast nephropathy. We are going to hear today tumor infiltration of the kidney. We can have acute kidney injury after nephrectomy because of renal cell carcinoma. acute kidney injury can follow stem cell transplant. We can have treatment-related hypertension. We can have treatment-related proteinuria. There are certain medications which can cause hypertension and proteinuria. And of course, cancer treatment in renal transplant patients is another whole different world. So, as we said, acute kidney injury is very important here. Probably about 18 to 27% of the patients with cancer in some point of their course of disease will end up having acute kidney injury. There could be different reasons for that. Again, the goal of this talk is not going through the detail. I just want to give you highlights and idea. So we can have acute kidney injury because of conventional chemotherapies. There are lots of conventional treatments and chemotherapies that can cause kidney problem. And we need to be aware of that. We need to be aware how to handle those and how to help oncologists. Ifosfamide, methotrexate, pemetrexate, cyclophosphamide, gemcitabine, they all can have kidney problem. Or we can have kidney problem because of new targeted therapies. There are lots of new targeted therapies, and each of them can cause problem. We are aware of some of their side effects, renal side effects, I mean, and some of them we don't know. If you just do literature search, you can see lots of case reports every day popping up because someone found new kidney problem following one of these targeted therapies. So we got to be mindful and aware of these. And of course, immune checkpoint inhibitors. They are one of the major treatments for cancer patients nowadays. They are being used to treat several different types of cancers. They can have different kind of side effects. They can involve different organs, and kidney is one of them. And today we know a whole lot better about renal side effects of immune checkpoint inhibitors compared to what we knew 3-4 years ago. And talking of immune therapy, it's not just limited to immune checkpoint inhibitors. We have immune therapy treatments, which could be non-immune checkpoint inhibitor, like CAR T therapy. That can also have its own certain problem with kidney. Or you could use pro-inflammatory cytokines, such as high-dose interleukin-2 or interferon alpha, and they can also have kidney problems. So immune therapy could be in different lines, and each line could have its own problem with kidney. Talking of renal side effects, we can never forget about electrolytes. We can have electrolytes because of CAR T therapy, and of course, electrolyte problem is not limited to CAR T. We can have electrolyte problem in other chemotherapy or targeted therapies or different reasons for electrolyte problem. I'll briefly get in touch with that shortly. So this is like nicely showing you that all parts of nephrons could be involved either because of conventional therapies or because of newer therapies. So we really need to help our oncology colleagues to help our patients who have cancer and are getting side effects because of these kind of therapies. And back to electrolytes. All kind of electrolyte problem can happen during cancer treatment or just because of cancer itself. Magnesium problem, calcium problem, phosphorus problem, sodium problem, potassium problem. And we also need to be aware of pseudo electrolyte problem, which is not uncommon in cancer patients. You can have all kind of pseudo electrolyte abnormality in cancer patients. Today we are going to learn about monoclonal gammopathy related kidney disease. This is also a big part of onconephrology discussion. So acute kidney injury in patients who have myeloma. So we are helping our oncology colleagues in this area also. Thrombotic microangiopathy. Thrombotic microangiopathy could be treatment related. This could be seen after stem cell transplant. This is one of the important areas which onconephrologists are interested and can happen, and we need to be aware of that, and we need to know how to handle it. Stem cell transplant is a big area in oncology, and of course, stem cell transplant is not coming free of renal side effects. Patients who get stem cell transplant could develop acute kidney injury, or over the time, they can slowly decline their kidney function for different reasons and end up having some degree of chronic kidney disease. We can have all sorts of glomerular pathology because of cancer. It could be IgA nephropathy, it could be crescentic GN, or any other type of glomerular pathology just because of the cancer. So another important area in onconephrology is cancer drug dosing in chronic kidney disease and dialysis. So always we are being asked, if the patient is on dialysis, when should the patient receive this treatment or that treatment? Is this dialysable or it's not dialysable? So this is another big area which onconephrologists are involved. So this was just a brief highlight of what onconephrology is all about and how we as onconephrologists are helping our oncology colleagues and of course our patients. But what is the history of onconephrology? How did it come to the world and how it is added as a subspecialty of nephrology? And it's a very fast-growing field now. This slide is actually from our editorial in Journal of Onconephrology when we announced American Society of Onconephrology a couple of years ago. So we can discuss about onconephrology in different categories: research category, awareness, and education. If I just want to summarize this slide for you, really prior to 2005, 2007, there was not much discussion about onconephrology. The first textbook in this area was published in 2005. And of course, over the time, more review articles were added, then local societies started to form and more publications. So about research, originally, most of the studies and publications were limited to review literatures. As time goes by, then more original studies started, and now we know more about different aspects of onconephrology, not just based on review, but based on actual original research. So Journal of Onconephrology was started in 2017. As you see here, ASN put the first onconephrology session in 2009, and first ASN pre-course was in 2013. In 2015, annual onconephrology symposium was started, and since then, every year we have annual onconephrology symposium. So the field of onconephrology, it was ready for big moves and bigger steps. So back in 2021, so my two great friends, Dr. Shruti Gupta and Kenar Javari, they started taking that big step. So they contacted with onconephrologists from different academic centers in the United States. They formed founding members. I had a call from Shruti and Kenar, and also Biru Vorkane, who is another current co-president of ASON. And we had lots of discussion. We had, different ideas which we shared, and eventually, with great leadership of Shruti and Kenar, this was done. So this is a timeline of Onconephrology Society. Discussion was started in 2021. We had the first meeting with founding members in October 2021. Then we received article of incorporation from the state of Ohio. Our logo was formed. We started creating the website in December 2021. And at the end of December 2021, we officially announced existence of and formation of American Society of Onconephrology. So the goal of ASON is promotion of research, clinical activity, and educational related activities in onconephrology. So here you see the current officers, Dr. Sharon Lacha, she's the current secretary of the society. Dr. Nelson Long, Nelson is very well known to Iranian nephrologists. I believe in 2019, actually, he was in my beautiful hometown, Tabriz, and had lectures in annual Iranian Society of Onconephrology. My great friend, Biru, with me, we are current co-presidents. And here is our committee chairs, great, knowledgeable and active people from different academic institutions around the United States and Canada, which are moving this society forward very strongly. So the question is how to get involved. So you can become a member of ASON. That would be great, if you can become a member. We have lots of activities going on, lots of educational courses. You could get involved with research activities and different other activities in the society. There is a WhatsApp, which is a chat group. This was actually formed by Kenar, and it's a very active group. There are more than 200 onconephrologists from across the world, actually, and different ideas and patients' information, they're all shared there. If we don't have answer, we have question, we share, and we get ideas from other onconephrologists. So the last but not the least, just want to let you know that this year our Onconephrology Symposium is going to be in Houston, Texas from October 6 to 7. This is also virtual, so you don't have to be here physically. You can register and you can participate and enjoy the lectures, which are going to be great. So that is all I have today, and I hope I was able to give some idea of what onconephrology is all about and what are we doing here in the United States in this area.
Great. Thank you, Dr. Rashidi. So we'll go ahead and move on to our first talk of the morning or evening. Dr. Naoka Murakami, she is a current assistant professor of medicine at the Harvard Medical School in Boston, Massachusetts. She completed her general and transplant nephrology fellowship at Brigham and Women's Hospital, Massachusetts General Hospital, and she's highly involved in the didactics at Brigham and Women's Hospital for the general and transplant nephrology division. She's an avid researcher. She's got multiple prior research awards and is currently funded through NIDDK with her research focusing on immune signaling and regulation of the renal allograft. So happy to have her give this talk.
Wonderful. Thank you so much. Let me share the screen here. Okay. You guys seeing the screen okay?
Yes.
All right. Fantastic. Okay. Good morning or good evening, everyone. My name is Naoka Murakami. I'm super excited to talk about the checkpoint blockade and kidney disease. This is my disclosure. And today I'm going to talk about checkpoint blockade and kidney injury using two clinical cases to talk about non-transplant patients and kidney transplant recipients. So let's start with the non-transplant patients. So case number one, 72-year-old lady with a stage 4 lung cancer receiving the combination therapy of carbo, PEM, and pembrolizumab, which is anti-PD-1 and checkpoint blockade. After 3 cycles, thankfully PET-CT showed significant improvement. However, 4 months after initiation, she came in with a creatinine of 4.8 from baseline 0.8. So this is significantly, elevated creatinine, stage 3 AKI. So past medical history included the GERD, and she was on omeprazole. Exams are benign, and creatinine was elevated in the lab. PSH was a little bit high too. Urinalysis showed a massive leukocyturia and hematuria, and then urine protein creatinine ratio was 0.5. So what's going on in this case? Is it pre-renal or acute tubular interstitial nephritis or some immune complex mediated disease or post-renal obstruction? Let's think about the case together. So before going in there, I'd like to review the checkpoint blockade history. So since approved in melanoma in 2011, which is already more than a decade ago, many cancer species, including lung cancer, kidney cancer, received the FDA approval. So now 30 to 40% of patients diagnosed with the cancer are eligible for the checkpoint blockade. And it's estimated that 240,000 patients are eligible for the checkpoint blockade. So this is very big population. So how the immune checkpoint blockade work? It works by unleashing the brake against the cancer immunity. This is a cartoon showing the interaction of the T cells and the antigen presenting cells and tumor cells. Basically, the T cells, in order for the T cells to be fully activated, they need 2 signals. One is the interaction between T cell receptor and then MHC and the antigen presenting cell. The second signal is the co-stimulatory signaling between CD28 and the T cells and CD80-86 and the antigen presenting cells. However, if these T cells express co-inhibitory receptors such as CTLA4 or PD-1, PD-L1, these T cells cannot be activated to kill the tumor cells. So the idea of the checkpoint blockade is to give blocking antibody against this inhibitory signaling, such as anti-CTLA4 ipilimumab, anti-PD-1 like nivolumab, pembrolizumab, or anti-PD-L1 atezolizumab, avelumab, to unleash this inhibitory signaling, thereby T cells can kill the tumor cells effectively. However, these therapies come with a cost, right? So immune checkpoint blockade comes with an immune-related adverse event, IRAE. As you can see on the left-hand side, it can affect almost all systems of the body. The skin rash being the most common, followed by GI systems such as hepatitis or colitis, and it can get, fatal. Can cause severe pneumonitis or myocarditis, and a patient can die from that. For nephrologists, important to know that it can cause acute kidney injury or kidney disease, such as interstitial nephritis or glomerulonephritis. It's also interesting to see these complications come in a different tempo. As you can see here, this is the time from treatment initiation. Skin rash present very early, 2 to 4 weeks post initiation of the therapy, followed by colitis, 6 to 8 weeks. And then our renal complication comes a little bit later phase, 16 to 18 weeks after initiation. So what is the prevalence of checkpoint blockade associated acute kidney injury? As Dr. Rashid showed in his slide, all comers of AKI in checkpoint blockade treated patients, it's about 16-17% of the patient. But if you focus on the checkpoint blockade associated AKI, the prevalence is around 2 to 5%. What about the clinical characteristics of the checkpoint blockade associated AKI? So there have been 2 major multicenter retrospective cohort study published in 2021 from Dr. Gupta's group. They included, multiple AKI cases compared to 2-fold control cases, and they showed very nicely, this is the cumulative frequency showing the median onset of 14 to 16 weeks from checkpoint initiation, and the AKI can be very severe. Their cohort showed a stage 2 AKI was for 40% of the patients. Stage 3 AKI was observed in almost 60% of the patient. And interestingly, 9 to 10% of the patient needed dialysis due to the checkpoint blockade. So this is very important category so that we should watch for. What about the urinalysis finding of the checkpoint blockade associated AKI? As in our patient, urinalysis would show leukocyte esterase, blood in more than half of the patients, and sediment would show pyuria, meaning, leukocyte in the urine. And we can also see proteinuria, but it can be small amount. What about the risk factor of the checkpoint blockade AKI? So two, multi-center cohort study examine what are the clinical variables that are associated with the checkpoint blockade AKI. It turned out if the patient had a lower eGFR at the time of start of the checkpoint blockade, they had a higher chance of AKI. And then also, interestingly, proton pump inhibitor use like omeprazole, esomeprazole was also associated with a higher chance of checkpoint blockade AKI. And then also if they are on a combination of checkpoint blockade, such as nivolumab and ipilimumab, they are also at a higher risk. And also clinically important extrarenal IRAE can be a hint to diagnose checkpoint blockade associated AKI. As you can see in the bar graph, the patient had more than 40% of the patient had more than one non-renal IRAE, such as skin rash or colitis, at the time of the presentation of the acute kidney injury. So if you see the patient with the AKI, who's on a checkpoint blockade and then see a rash and colitis, that could suggest, this may be checkpoint blockade associated AKI. So what about other diagnostic tools or biomarkers for this entity? Urine findings, I talked about the hematuria, leukocyturia, but this is non-specific, unfortunately. And then kidney biopsy is the gold standard, but unfortunately it is performed only in less than half of the patients because, the oncologists tend to treat the patient with a steroid empirically. But however, if they're biopsied, 93% of the patient had consistent findings with a tubular interstitial nephritis. The search for biomarkers in plasma and urine are ongoing. Several studies, very nice study published in JCI Insight and JITC recently showed a elevated plasma circulating IL-2 receptor, as well as urine cytokines such as CXCL9 might be a biomarkers for the checkpoint blockade associated AKI, but we need more study to use it in a clinical setting. How about imaging? So there are a couple of studies suggesting the patient who has the serial PET scan for the cancer staging, it might be, highlighted area in the kidney in the setting of acute interstitial nephritis, as you can see here in the left side, and then also in the right imaging. So this could be an adjunct test for the diagnosis of acute interstitial nephritis. So going back to the case 2, this is the same clinical vignette, just highlighting the keywords. 4 months after initiation of checkpoint blockade, she was on omeprazole and extrarenal IRAE. Thyroid markers are elevated. She had leukocyturia and hematuria and proteinuria. So we performed the ultrasound, which was normal. Creatinine did not improve after IV fluids, and then kidney biopsy was performed. So biopsy showed, massive infiltration of mononuclear cells. This is the H&E staining of the kidney biopsy. You see a lot of blues. If you go into the higher power, you can see, mainly the lymphocyte infiltrate, but you can see some tubulitis as well as some eosinophils here and there. So from here, we diagnose is acute tubular interstitial nephritis. So we now need to think about how we should treat checkpoint blockade associated AIN. So fortunately, checkpoint blockade associated AIN responds well to steroid therapy. So this is the graph from Dr. Gupta's group, suggesting if you look at the all comers, 64% of the patient responded very well to the steroid therapy. And this is the cumulative frequency of how quickly they respond to steroid therapy. Again, they continue to recover to their baseline creatinine over the next 12 to 13 weeks. So based on these data, SITC recommended to start with a prednisone 1 milligram per kilogram with a slow taper over 2 to 3 months. So what about the predictors of kidney recovery after checkpoint blockade AKI? Is there any way to know who would respond to the steroid therapy? So this is, again, the same analysis from Dr. Gupta's group, showing that if the patient presented with a stage 3 AKI, very severe, they had less chance of recovery. However, of course, if they're treated with a corticosteroid, they tend to recover. And interestingly, if they're presented with a lower eGFR or they had a lung cancer as a cause of or indication of the checkpoint blockade, they had lower chance of recovery. And it is also interesting if they have a concomitant AIN causing medication such as omeprazole, probably by discontinuing, they had a little bit higher chance of recovery. So the case 2 continues. She was treated with a prednisone for 3 months, and now her creatinine plateaued 1.6. So a little bit higher than baseline, but she's doing fine. During this period, CT surveillance didn't show active tumor, but 1 month after finishing prednisone, CAT scan again showed the increased hilar mass in the reinitiation of checkpoint blockade was considered by oncologists. So what should we say as a onconephrologist? Should we consider re-challenge? So here again, our group shows some data on how likely the patient would have recurrent AKI when they were re-challenged. So as you can see here, this is the frequency of a recurrent AKI in the patient who got re-challenged. Fortunately, 84% of the patient didn't have no checkpoint blockade associated AKI. So in other words, in the flip side, we can say probably 15% or 20% only would have recurrent AKI. So here, probably should have the risk-benefit discussion with oncologist and the patient, with having this data, which way we should go. But this is very interesting and useful data. So going back to the, acute kidney injury differentials, a checkpoint blockade can also cause things other than acute interstitial nephritis. It can cause glomerulonephritis, for example. This is the systemic review paper published in a Kidney International Report reviewing 45 cases of biopsy-proven checkpoint blockade-associated glomerular disease. They found that the polyimmune glomerulonephritis is most common, causing 27%, followed by podocytopathy in 24%, and C3GN was found in 11%. So in these particular cases, kidney biopsies are very useful to understand the etiology of the kidney injury as well as the direction of the therapy. How about the electrolytes and acid base? Yes, checkpoint blockade can cause these issues as well. If you look at the all comers of the checkpoint blockade treated patient, 62% of the patient can have hyponatremia. The etiology can be SIADH or hypophysiasis, and 27% had a hypokalemia. And then interestingly, some cases of distal renal tubular acidosis, RTA, have been reported, and it can be mediated by autoantibody against type B ATPase. So this is very interesting entity, and we need to be aware. Okay, so let's move on to the kidney transplant recipient case. So this is a transplant patient, 58-year-old lady, kidney transplanted 24 years ago, unfortunately developed a metastatic melanoma. She was started on ipilimumab, nivolumab combination therapy 3 weeks ago, and then she now came in with a decreased urine output and hematuria. She was only on the prednisone 5 milligram daily. In terms of the lab, creatinine was elevated 3.4 milligram from 1.2 at baseline, and the urine protein creatinine ratio is elevated, and the urine showed protein in blood and leukocyte esterase. Again, massive RBCs and WBCs and cast and kidney biopsies performed. So what we're going to see in the kidney biopsy, acute cellular rejection, BK nephropathy, membranous nephropathy, or metastasis. So in this case, I would say, acute cellular rejection will be most likely. Before going into the details, I like to highlight malignancy is a major cause of death after the kidney transplantation. This is the pie chart showing the cause of death in dialysis patient on the left and transplant patient on the right-hand side. As you can see here, malignancy showing the gray pie is the third. Now I think is the second most frequent cause of death, with the infection cause following the cardiovascular is attributed to the malignancy. So this is very important issue in the post-transplant ward, and but immune checkpoint inhibitor in this kidney transplant population is very challenging, because in addition to think about immune checkpoint blockade and tumor response, we need to think about how we manage the immunosuppression, and how about the kidney allograft rejection risk. So when we started to look at the clinical response in the kidney transplant recipients, we had very small data on this field. Initially, it was reported that ipilimumab, which is anti-CTLA-4, might be a good option for them because they didn't see rejection. But the same group reported that nivolumab, anti-PD-1, caused rejection. So since then, several studies show the rate of acute rejection is probably 30 to 40%, but we didn't know the association between rejection and an overall survival based on in the patient with kidney transplant patient treated with a checkpoint blockade. So in terms of the efficacy, no study really didn't have no study has tested the clinical efficacy. So we set out to do multi-center observational study in this cohort. So we collected 70 cases and looked at the clinical characteristics of acute rejection. We found that 42% of the patient, which is 29 cases here, had acute rejection. So we found that the rejection can happen very, very quickly. So we found that the median onset of rejection is 24 days after starting checkpoint blockade. So this is 3 weeks after starting checkpoint therapy, which is a nice contrast compared to the non-transplant patients whose median, onset of the acute kidney injury is 16 to 17 weeks, which is very, very late. So this is again the cumulative frequency. You can see the sharp peak here of acute rejection 1 to 3 weeks after starting the checkpoint blockade. And interestingly, if they are biopsied, both T-cell mediated rejection and antibody mediated rejection are both common, and rejection can be very severe, and 65% of the patient needed to go back to dialysis once they are diagnosed with a rejection. So what about the risk factors for allograft rejection? Here, we looked at the several clinical variables, and we found that the mTOR inhibitor used, such as sirolimus or everolimus, was associated with a lower risk of rejection. And also, we found that if their patients are on a 2-agent immunosuppression, a 3-agent immunosuppression, such as combination of sirolimus and prednisone, they were at the lower risk of rejection here, which biologically makes sense because they are on a more immunosuppression, so they tend not to reject. This is again showing, comparing the rejection-free allograft survival in the patient who were treated with mTOR inhibitor and the solid line compared to no mTOR emitter in the dotted line. As you can see here, allograft survival is better in mTOR emitter treated group. So this might be a sign of benefit of mTOR emitter. How about the efficacy? Efficacy of the checkpoint blockade in, something wrong. I'm sorry. Okay, resharing again. Okay. Okay, so we compared the outcomes of the skin cancer, patients with a skin cancer being treated with a checkpoint blockade and non-checkpoint blockade, which is a historical cohort. Both are very well matched, age around 62 years and male predominant, 12 to 11 years after the kidney transplant. Most of them had metastatic disease or unresectable stage 3 skin cancer. Baseline creatinine was 1.4 and 1.5. And if you look at the tumor response, in the checkpoint blockade treated group, 33% of the patient achieved the complete remission or partial response, compared to only 8 to 9% of the patient achieved the response in a non-checkpoint blockade therapy. This is the overall survival curve, again, showing the checkpoint treated group in the blue and non-checkpoint treated group in the orange. You can see some better or prolonged overall survival in a checkpoint group treated group. So that might suggest the benefit of checkpoint blockade used in this specific population. So can we mitigate the rejections, which is the million-dollar question? And this is the index case study published in New England Journal of Medicine a couple of years ago. They use very specific regimen of the immunosuppression, combination of prednisone and sirolimus. So they started high-dose prednisone 1 week prior to initiation of the checkpoint blockade, and then taper down to 40, from 40, 20 to 10. At the same time, they used the sirolimus. By doing this, they were able to treat the cancer effectively, as well as mitigating the rejection. So following up on this index case report, there have been 3 small clinical trials ongoing. So this is a summary table of these 3 studies, 1 in Australia, 2 in the United States on the right. So in Australia study, they included any cancers, any metastatic solid tumors, and then treated the patient with nivolumab. They included 17 patients and 2 had rejection, so 11.7% rejection rate, and overall response was around 50%. In contrast, in this Johns Hopkins trial, they included only skin cancers and treated the patient with nivolumab plus minus ipilimumab. They used a tacrolimus and prednisone combination in this cohort. They recruited 8 patients and 2 had rejection, and then overall response is 33%. So our study, Contract 1, we included only skin squamous cell carcinoma in the kidney transplant patient treated with a semipilimab, which is anti-PD-1. We used specific combination of mTOR and dynamic prednisone, as a case in New England Journal did, and we recruited 12 patients and none had rejection, and we achieved the overall response of 45%. So we're very much excited about the result. This is the summary of what we're exactly doing, running the mTOR inhibitor at the range of 4 to 6 and prednisone taper as, in the New England Journal paper. So we're hoping to bring that, study to multi-center and as a next step. And in summary of this talk, I just wanted to highlight the contrast between the transplant patients and the non-transplant patient. Kidney transplant patients at a higher risk of rejection, 30 to 40%, compared to 2 to 5% in the non-transplant patient. Early onset, 3 weeks versus 16 weeks, and steroid refractory versus good steroid response in a non-transplant patient, and then their higher rate of requiring dialysis in kidney transplant patient versus non-transplant patient. So this is, the conclusion here. Checkpoint blockade can cause acute kidney injury and transplant rejection, and we need more mechanistic studies and biomarker studies to know better about, how to diagnose and treat the checkpoint blockade associated acute kidney injuries. So I'd like to thank the Checkpoint Kidney Transplant Consortium, as well as the ASON, for this wonderful opportunity to talk here today. Thank you.
Wow, that was great, Naoka. Thank you so much. We do have a couple questions, if you don't mind. So the first question is, with immune checkpoint inhibitors, is there any thought to why only some patients will have a recurrence of AIN after rechallenge? Any understanding about the mechanism?
Yeah, great question. So, we know that only 15 to 20% of the patient have recurrent AIN, but we don't know the mechanism yet. So that's our target of the research next step.
That sounds great. And then another question is, in the cases of polyimmune crescentic GN associated with immune checkpoint inhibitors, were they also ANCA positive by serologies?
I think some are ANCA positive, but most of them are negative, I think.
Okay. And then the last question is if kidney allograft rejection occurs after immune checkpoint inhibitors, do you treat the rejection with just steroids or any other do you think of it the same way or differently?
Yeah, that's a great question. We usually use steroid as a mainstay because, we don't want to throw, for example, thymoglobulin that can deplete all the T cells that can also, slash the anti-tumor response. So it's, it depends on the discussion with the oncologist, but we usually use the steroid only.
Perfect. All right, great. Well, thank you so much. We'll go ahead and move on to our second talk. Our next talk is by Dr. Sabine Karam. She is a current assistant professor of medicine at the University of Minnesota, but prior she was longstanding faculty at the University of Illamahmed. I'm going to say it wrong, Illamahmed, in Lebanon, where she served as the director of the Division of Nephrology and Hypertension at St. George Hospital University Medical Center in Beirut. Prior to her returning to the U.S., she did complete her nephrology fellowship at the George Washington University Hospital in Washington, D.C. She's highly published in the field of general nephrology and onconephrology, and at her current position, she is responsible for the didactics of onconephrology and peritoneal dialysis to the nephrology fellows at the University of Minnesota, and is involved in the American Society of Nephrology Onconephrology core curriculum. So thank you so much for your time.
Good morning. Thank you for the kind introduction. First of all, I would like to say hello to my great friends in Iran, all those great ladies who are really leading Iranian nephrologists, Professor Shokoufe, Professor Savage, Professor Shahrazad. It's great to be here today. Thank you for giving me this opportunity. So today I'm going to talk about the approach to monoclonal proteins. It was hard to coin the subject in 20 to 30 minutes. It's such a wide subject, but I'll try my best. I have nothing to disclose. So today we're going to try to define the different types of monoclonal gammopathies and estimate their prevalence. We're going to describe briefly their pathogenesis. We're going to discuss the diagnostic modalities, and we're going to illustrate the current principles of management. So I'll start with talking about what is a monoclonal gammopathy. So basically, you have to find a monoclonal immunoglobulin, either in the serum or the urine or both. It can be in an intact form or it can be a fragment. And it's usually produced by an expanded clone of either B cells, plasma cells, or lymphoplasmacytic cells. In the case of plasma cells, it's mostly IgG. In the case of B cells and lymphoplasmacytic cells, it's mostly IgM. And that's actually a very important distinction, because when we can't really isolate the underlying clone, then we can try empirically to treat it by postulating that if it's IgM, it's coming from a certain disorder, a certain type of B cells, and if it's IgG, it's coming from another type. So what do we know about the epidemiology and prevalence? And I think this is a very important question to try to answer, because obviously it would dictate whether we should be screening everybody for that or not. And interestingly, what's quoted in, I would say, more than 90% of the papers in the literature is a monumental work done by Professor Kyle from Mayo Clinic in Onset County. He started from the 60s collecting data about monoclonal gammopathy, coined the term in 1978. We all know his landmark paper published in 2006 in the New England of Medicine, Journal of Medicine, where he got from a sample of around 21,500 individuals and studied them using SPEP and immunofixation. So this is a very important point. So at that time, the use of serum-free light chain assay was not prevalent. And by doing that, he found that asymptomatic monoclonal gammopathy was found in approximately 3% of his population more than 50 years and more than 5% if more than 70 years. Many years later, so from the same institution, Dr. Murray used mass fix and took some samples from the same population that Dr. Kyle studied. And by using this more sophisticated technique, he was able to actually prove that asymptomatic monoclonal gammopathy is indeed found in actually 5% of the population of more than 50 years and more than 7% of the population of more than 70 years. And this is an important concept as more and more sophisticated techniques are being developed to screen and trace monoclonal gammopathies. Dr. Kyle also showed us that the prevalence was twofold higher in Blacks compared to whites, and that it could regress in 2 to 5% of the cases. And this is where actually we know now that there is a different, I would say, epidemiology of this entity according to the ethnicities. And so not many people know that, but in the Asian population, actually, the prevalence seems to be much lower. And so there is some, substantial data coming from Thailand, Hong Kong, and Japan. And as we can see, this prevalence is much lower. What they used to screen in that in those population was SPEP with immunofixation and serum-free light chain. So a bit more sophisticated techniques than the initial population used by Robert Kyle. And then what we have also coming from Iceland, and I think this is the most comprehensive epidemiologic study to date. And I guess the more your sample is larger, the more you can have an accurate estimate. So in around 150,000 individuals from Iceland, more than 40 years of age, 5% were actually found to have monoclonal gammopathy by SPEP and free light chain assay. So here is where I wonder if there's anything done in the Iranian population, which is 90 million people, and it's probably ethnically also distinct from the Caucasian population that Robert Kyle studied. Now, we found MGUS, and then what is the over risk of progression? So this is again coming from Robert Kyle, but this has also been confirmed in other studies. So the over risk of progression is around 1% per year to any disease that has an impact on health. But obviously, certain people are more prone to progress. So the risk of progression at 20 years, if there is an abnormal serum-free light chain lesion and protein of more than 1.5 gram per deciliter, is 55% in patients with IgM and 30% in non-IgM patients. In general, an unprotein-related disease is present in 10% of patients with a hematologic diagnosis of monoclonal gammopathy. What also Robert Kyle showed us is that the overall survival of MGUS patients, independently of whether they develop a malignancy or not, or any hematologic disorder, is shorter than in a matched control population. So what is the natural history of any monoclonal gammopathy? So there is a clone which produces this monoclonal immunoglobulin. Initially, it's quiescent. Then we talk about intermediate or indolent disease, and the distinction between quiescent and intermediate or indolent disease is is a pure number. It's about the mass of the clone. And then at some point, the burden of the secretion becomes so high that a malignancy can develop. And this is classically how people had been thinking about those disorders. So, and the hematologic community, the oncology community, basically tells you that initially you start with MGUS, with an M protein of less than 3 grams per deciliter, a plasma cell burden of less than 10% on a bone marrow, and no any manifestation, no any abnormal manifestation. Then you can progress to a smoldering myeloma, and that's defined by, as I told you, more of this monoclonal immunoglobulin. And this is where a renal point gets added with a urine M protein of more than 500 milligrams per 24 hours. Eventually, you could develop myeloma. And so the initial criteria of myeloma were clonal plasma cells of more than 10% or a biopsy proven bony or extramedullary plasmacytoma, and a myeloma defining event was CRAB. So the myeloma, the International Myeloma Society added some criteria in 2014, which predict anyway having a disease independently of any other manifestation due to, again, the large mass of cells involved. And that would be a clonal bone marrow plasma cells of more than 60%, a ratio of involved and uninvolved serum-free light chain ratio of more than 100, and focal lesions on MRI at least 5 millimeters in size. They also added recently the light chain cast nephropathy as a defining event, and that's because inalytically, when you have more than 150 milligrams per deciliter of light chain, you're going to have sooner rather than later multiple myeloma, and you're going to have light cast nephropathy. So those are the definitions of the Hematologic Society in terms of plasma cell disorders. As you can see, it's mostly about numbers, so it's quantity and not really quality. While when you come to the definition of lymphocytic and lymphoplasmacytic disorder, there is a general consensus to treat CLL if you have more than 5,000 abnormal lymphocytes and anemia and thrombocytopenia, or lymphadenopathy and or splenomegaly. And in the case of LPL, if you have infiltration of the bone marrow of more than 10% and at least one anemia or thrombocytopenia or cryoglobulinemia and hyperviscosity syndrome. And what's striking about this, despite what we know about those diseases and the high incidence of renal events, there is no mention of any renal disease here to treat. And this is where the IKMG comes into place and tells us for the first time about the MGCS concept, where it's not only about the tumor mass, but also about the quality of the immunoglobulin and the different mechanism by which this immunoglobulin or this abnormal protein can be nephrotoxic. And it has to do with its physicochemical properties, with activation of the alternative complement pathway, with abnormal cytokine production, et cetera, et cetera. And so here comes the definition of MGRS, which was coined in 2012 and tells us that MGRS is a monoclonal gammopathy without overt associated lympho and or plasma cell proliferation, because in this case, we just talk about malignancy with renal involvement, and associated renal symptoms related to the monoclonal immunoglobulin or to the B-cell clone by any mechanism other than tumor burden. And the different pathogenetic mechanisms that have been postulated, but we obviously are far from having understood the whole story, either have to do about the direct deposition of the abnormal protein by immune complexes deposition, or abnormal conformation, such as the case of amyloidosis, either in the glomerulus or the tubulointerstitial, knowing that the vast majority of MGRS are glomerular disease, or through an indirect mechanism that's either autoantibody mediated, for instance, against the factor H, or by continuous activation of the alternative complement pathway by inhibition of the C3 convertase, or in the case of POEM syndrome, by the secretion of VEGF. Now, let's talk about the epidemiology and prevalence of MGRS per se. So how often are we likely to find MGRS on a kidney biopsy? So prior to the IKMG coining that term and elaborating classifications, there has been some efforts done in that sense. They included, however, renal pathologies that were associated with any monoclonal globulin and could be in the setting of malignancy. And they also included light chain cast nephropathy. The two largest series that I could find were one coming from Dr. Herrera in Louisiana and the other coming from Dr. Fogo in Vanderbilt. And the largest coming from Dr. Herrera demonstrated that in 2.5% of kidney biopsies done in patients who had monoclonal gammopathy, they had some renal pathology associated with light or heavy chains, and 1.75% when the light chain cast nephropathy was excluded. More recently, we have two very good retrospective studies that showed more or less that MGRS-related disease present in approximately 40% of patients with monoclonal gammopathy who undergo a kidney biopsy. So the first one, as I'm sure most of you are familiar with, comes from Mayo Clinic. So again, the place of birth of monoclonal gammopathies. So they took so between 2013 and 2018, they had 6,300 biopsies that were done. They took the biopsies where there was concomitant monoclonal gammopathy isolated. And what they found is that, again, so 40% had MGRS lesion, 60% had non-MGRS lesion. The most common was AL amyloidosis. Among the MGRS lesions, it was present in 44%. The second most common was PGN-MID, while the most common lesion that was non-MGRS among those patients was around 24%. And this came from 160 biopsies. The predictors of finding MGRS per their analysis were the presence of proteinuria of more than 1.5 gram per day, hematuria, and an abnormal free light chain ratio. And what they also found is that 2.5% of patients overall who had a monoclonal gammopathy had a kidney biopsy, and the predictors of performing a kidney biopsy was a young age, a serum creatinine, and a 24-hour urine protein. So, I mean, obviously, this study comes with several limitations. Mayo Clinic is a very large referral center. There might be a referral bias, a selection bias. They also use routinely more sophisticated techniques to diagnose those disorders than the average center, I would say, not only worldwide, but also in the US. And this is where we have another study from China, going over a much longer period of time. So the one from Mayo Clinic stemmed from 2013, and probably the cutoff of 2013 was not just used for convenience, but also because the classification and the term was first used in 2012. So that study from China studied biopsies from 1999 to 2020. The sample was larger, to 61 patients. It seems that in China also, but initially they only had 4,000 cases, which tells us of monoclonal gammopathy, which tells us again that probably the prevalence is much lower in any Asian population. But then from this 4,000 patients, they did more biopsies, which also tells us that some of our data can have to do with the local practice and the cultural environment. But anyway, interestingly, the most, so again, we found 40% of MGRS, 60% of non-MGRS. The most common entity was again amyloidosis. So that's a no-brainer. And this is where I personally think that amyloidosis is probably an entity apart and should probably be excluded of the other MGRS. It's just more easily defined, more easily treated, better codified. We have solid data while the others are much rarer, more poorly understood, and we definitely need more data and more studies to really know whether their description is accurate, whether their classification is accurate, and what is their actual pathogenesis. But anyway, in the study, the most common entity after amyloidosis was MIDD, followed interestingly by thrombotic microangiopathy, while the non-MGRS lesions comprise mostly membranous nephropathy, which is an extremely interesting finding, knowing that certain cases of membranous nephropathy have also been associated with monoclonal gammopathies. What we also know about monoclonal gammopathy is that it can be transient, and you can have micropeaks that are triggered by certain conditions such as aging, immunodeficiency states, or immunosuppressive treatments. And often in that case, you can see only very small amounts of serum monoclonal immunoglobulin that are demonstrable only by a sensitive method such as immunoblotting. And there are usually of the IgG subclass. Interestingly, this is also what's found most commonly in PGNMID. That goes beyond the scope of this talk, but PGNMID is now thought of several entities, not just one entity, where the light chain component is certainly associated with monoclonal immunoglobulin, but the one with IgG3, we're not so sure. And in general, in transit monoclonal gammopathy, there are similar frequencies of the kappa and lambda isotype. While in general, in multiple myeloma and GAMGAS, there is obviously more kappa, way more kappa than lambda. Now, how we detect a monoclonal protein? So I think most centers over the world now combine both an SPEP with immunofixation and a serum-free light chain assay. Immunofixation in general is a qualitative study, while the SPEP is a quantitative study. By combining an SPEP with a serum-free light chain and a UPEP with serum immunofixation, we can decrease the rate of dissection to as low as 50 milligram per liter, knowing that a UPEP is usually less sensitive than an SPEP, requires a 24-hour urine collection, can be cumbersome to perform. Free light chain in the urine are definitely not indicated. The assay has not been validated. There is variable absorption according to individuals, and basically they should never be used to make any diagnosis of that sort. In general, there is also a consensus that there is what we call a renal ratio, whereas in patients with no CKD, the ratio is 0.3 to 1.65. While in patients with CKD, you can go up to 3.1 and have a normal ratio. And that has to do with, in general, people tend to secrete twice more kappa than lambda, but lambda has a slower elimination. And so this is where the ratio gets distorted in renal failure. So the same people that have been doing this monumental study in about the prevalence in Iceland have come up with reference in intervals according to the stages of EGFR. And I think that only makes sense. Obviously, the more advanced decrease in renal function you have, the more this ratio is going to be distorted and altered, and you cannot interpret the ratio the same way in a patient that has, let's say, a GFR of 55 than in a patient who has a GFR of 20. So that's interesting. Now, how often do we find a monoclonal gammopathy in patients who have some, by those techniques, in patients who have, a disease that's related? So obviously in multiple myeloma and smoldering myeloma, when you combine SPEP and immunofixation and the free light chain assay, you're going to find it always, because you have a lot of those chains. So and you're using quantitative, you're combining quantitative and qualitative analysis. In AL amyloidosis, you also have a pretty good sensitivity, and you can reach 2% more by adding a UPEP with immunofixation in AL amyloidosis. However, in other monoclonal gammopathies and in other types of MGRS, this is less obvious. And there's certainly a minority of patients only who get a clone identified in PGNMID. And in the best case scenario, you can find 20 to 30% by serum SPEP with immunofixation in PGNMID. While, for instance, in C3 glomerulopathy and TMA, you have a very good sensitivity of those tests. In immunotactoid and type 1 also, you many times cannot isolate a clone. Now, how do we validate a diagnosis of MGRS? So you suspect it, obviously, when when you have renal symptoms in a patient with known monoclonal gammopathy, and or you have a kidney biopsy that shows a monoclonal immunoglobulin-related renal region. And ideally, you want to find monoclonal deposits, inclusions in a patient with or without monoclonal gammopathy. And so basically, you need to analyze the renal symptoms, but you also need, in certain cases, to search for extrarenal manifestations. So PGNMID is usually only renal, but amyloidosis, by essence, is a systemic disease with involvement of many organs. The kidney biopsy is the ultimate way to make the diagnosis. It allows you to characterize the pathogenic monoclonal immunoglobulin and also identify the underlying clonal B-cell disorder. And so basically, you would think of doing a kidney biopsy if you have unexplained kidney disease, and that goes for everything. If you have other cause or risk factors for CKD, but an atypical presentation or clinical course, if you have suggestive extrarenal manifestations, if you're young, and you have to know that in general, the hemorrhagic complications are similar to any other indication. Ideally, to make the most possible accurate diagnosis, you shouldn't just rely on the traditional methods. If you can obtain laser microdissection with mass spectroscopy-based proteomic analysis, which is provided in selective center in the world, it really allows you to distinguish between just monotypic deposits versus true monoclonal deposits. And this is where also there is a constellation of findings that will allow you to make your diagnosis. So as I already told you, so in general, they can present, different entities can present slightly differently. Some of them have extrarenal manifestations, some don't have. For instance, light chain proximal tubulopathy is associated with a stress fracture in 40% of the cases. In certain cases, you have more often you find hypocomplementemia in the blood, and that's the case for monoclonal immunotactoid, for instance, and type 1. And then some comes with deposits, other comes with non-deposits, some comes with organized deposits and non-organized deposits. And you can also distinguish the nature of the deposits in terms of fibrils, tubules, and crystals. And so basically, by putting together the different manifestations and the presence and the findings on kidney biopsy, you can make a diagnosis. It's also important to distinguish that certain types come with different types of immunoglobulin. And for instance, in the case of PGNMID, you mostly have IgG3 kappa. In the case, obviously, of C3, you have C3 deposits. In the case of type 1 cryoglobulinemia, you have mostly also IgG3, et cetera, et cetera. There is also a different epidemiologic, there is a different distribution in terms of how often you find those associated with MGRS and how often you find them associated with a malignancy, because you can find those lesions on a kidney biopsy in the case of pure MGRS and associated with a hematologic malignancy. And so, for instance, amyloidosis is associated with MGRS in 80% of the cases, and in myeloma in 16% of the cases only. While immunotactoid is associated with MGRS, and type 1 is MGRS in 50% of the cases, more or less. MIDD, same thing, the distribution is probably close to AL amyloidosis. Well, interestingly, PGMID in the vast majority of cases comes with MGRS. And this is where you obviously need to complete your renal workup with a hematologic workup, if that didn't happen before. And so combining a bone marrow aspirate. So it's interesting to note that in Europe, people mostly do bone marrow aspirate and don't do biopsies. In the US, we usually combine both. A total body MRI and PET CT scan is also important to look for any lymphadenopathy or any other extrarenal involvement. An important technique that's unfortunately only now still, again, available at select center and mostly in the research arena is immunoblot analysis. You need to know that, by the traditional techniques, usually we isolate antibody to the heavy chain, which is a constant region. And so you can confuse immunotypic deposit with monoclonal deposit, while basically the monoclonality comes from variable regions. And so immunoblot analysis is not only more sensitive, it's also highly more specific than immunofixation. And this is where, ideally, if you have it, it's essential to determine the monoclonality. Another rising method coming again from Mayo Clinic. So at Mayo Clinic, this technique, which is called MALDI-TOF or MASFIX, which goes for matrix-assisted laser desorption ionization time of flight. So at Mayo Clinic, MALDI-TOF is a technique now used in lieu of ASPEP with immunofixation. It has replaced it in routine practice and is slowly being introduced in the myeloma guidelines. So there are three methods of mass spectrometry assay. They differ slightly in the way they're done. So the most sensitive one is the MyRAM. It's, however, much more time and resource consuming than the MALDI-TOF. And this is why MALDI-TOF is being used in lieu of MyRAM at Mayo Clinic currently. And so, the authors of those that are using those techniques are currently advocating for using MyRAM to detect residual disease, for instance, in multiple myeloma, but to use MASFIX for diagnosis. What also those techniques bring on the table is that they allow to distinguish therapeutic antibodies from endogenous proteins. So again, more sensitive and more specific to detect a clone. Another very promising technique, so published by Vincent Javog from France recently, is the RNA-based immunoglobulin repertoire sequencing. And that comes actually from a bone marrow aspirate. So the interesting part about this technique is that you need only 1 milliliter of bone marrow aspirate, and you don't need a bone marrow biopsy. It's based on sequencing of the light chains. So again, allows you to isolate all the potential mutations and is extremely sensitive in light chains and in variable domains. Now, this technique is so sensitive that sometimes you can have polyclonal mutations. And this is where you need ideally to combine it with mass spectrometry in the kidney to really isolate and correlate which clone is actually causing the damage. And so Vincent Javog and his colleagues were able to show in a series of 16 patients, which initially had, the bone marrow was negative in 11 and the flow cytometry was negative in 7 to 12. They were able to isolate all the clones in those 16 patients and they match renal deposits. So this is a very promising technique. A few words about the principles of management. I think I already went way overboard in terms of time. There are important differences between treatment of monoclonal gammopathy associated renal disease and overt hematologic malignancy. So there is no hematologic indication for treatment. But interestingly, my friends, so most of the current recommendations coming for the treatment of MGRS are based on epidemiologic data coming from hematologists. The IKMG is right now conducting a multi-center study, international study, to come up with clear indications and criteria of responses for patients with LCDD. And this is led by hematologists. The IKMG suggests careful surveillance only in patients with stages 1 and 2 without evidence of progression and a proteinuria less than 1 gram per day. So as in anything in medicine, you have to weigh the risk versus the benefits of giving any of those toxic treatments. So basically, if you have an elderly, a very frail patient, you might elect not to treat them, especially if you think that this is pure MGRS and hence it's the kidney that's at stake and not his life. You also need to decide whether to treat if the patient is a potential candidate for future renal transplantation. So while the hematologic response is very well codified for hematologic malignancies and for AL amyloidosis, it's not codified at all for MGRS. And again, this is where IKMG suggests, but without any clear evidence and without enough data. I mean, what we have for a lot of those entities are case series. And that's also derived from the criteria of amyloidosis. So they think that you could consider that someone has a very good partial hematologic response if there is a difference between the involved and uninvolved free light chain of less than 40 milligram per liter or 4 milligram per deciliter, or a 90% reduction of the involved free light chain. And ideally, you would want to have a very strong hematologic response with a reduction of the involved free light chain to less than 2 milligram per deciliter. So this is where, if you have a very small clone, or if you don't have clone at all, this is where it becomes very hard to determine what should be your response. In terms of renal response criteria, so for the remission of proteinuria, you might notice here a clear difference between the criteria that are traditionally used for other glomerular disease and for monoclonal gammopathy. So this is again coming from hematologists, and they make a case for this, saying that in their case, they need to make quick decisions about whether they need to switch lines of therapy. So clearly a very different way of approaching things than the nephrology world. In general, the treatment of monoclonal gammopathy-associated renal disease is geared at the underlying clone. So if you have a plasma cell clone, you go for anti-myeloma treatment. Daratumumab is gaining more and more momentum for those entities, and is clearly emerging as a very sexy agent to use because you can use it alone. We're starting to have case series and even the first trial using daratumumab, a very tiny trial, 11 patients only, but still. If you have a B-cell or erythroplasmacytic clone, rituximab is the agent of choice, combined or not with cyclophosphamide and bendamustine. And if you have an unknown clone, you can just throw their daratumumab. Or if you have bortezomib, And throwing daratumumab comes from, again, the fact that people a few publications that show that a few people with PGNMID who had no clone isolated responded very well to daratumumab. And there is also a series of 5 patients recently published from Ohio State, which showed that daratumumab was efficient in 4 out of 5 patients with PGNMID that were resistant to bortezomib. Or you can elect bortezomib if you have IgG deposition in the kidney, and rituximab if it's IgM, and switch between one or the other. So basically, I already told you about daratumumab. I'm just going to tell you that it was tested in an open label phase 2 trial in 11 adults, and 9 out of 10 achieved at least a partial response, 3 achieved a complete response, and this is why now it's actually tested in a multi-center trial for MIDD. A very quick word about renal transplantation. It's the best option for the right candidate. It's a no-brainer. You need to eradicate the clone, otherwise you'll have a very high rate of recurrence. In the case of PGNMID, we have 2 series of 20 and 26 patients published where the recurrence rate was more than 90%. And I'm going to thank you. Here was the first depiction of the glomeruli by Mike Piggy in the 18th century. Thank you.
Wow, thank you so much. That was very comprehensive. I really appreciate it. We do have 1 or 2 quick questions, if you don't mind. So the first question is, I guess I'll paraphrase, is in what situations do you utilize the urine-free light chain ratio testing, and what do you think it's the most helpful for?
It's not helpful. It shouldn't be at all.
And then the other question is, do you advise a patient to get a stem cell transplant prior to a renal transplant? And how long do you suggest clone-directed therapy prior to kidney transplantation?
It depends on the type of MGRS. So in the case of light chain deposition disease, we've had autostem cell transplant done with very good results. It hasn't really been studied in other types of MGRS, and it should be the focus of further trials. How long do you suggest clone-directed therapy? I think this is also very variable. For amyloidosis, it's very well codified, for multiple myeloma as well, but for the others, we really don't know what to do. But also for amyloidosis, what's good about amyloidosis, provided again there are no extrarenal involvement, and again in the case of amyloidosis, we have good predicting scores, and we have enough trials to be able to draw conclusions. Patients could get treatment right after transplant, so they don't need to have achieved complete remission.
Great. Thank you so much. So we'll move on to our last talk of the morning and evening. This is by Dr. Chintan Shah. He's a current assistant professor of medicine at the University of Florida in Gainesville, Florida. He completed his nephrology fellowship at Wayne State University at the University of Florida, he's been a real self-starter. So he helped to establish their angiomyolipoma clinic, also their hyponatremia clinic, and the onconephrology clinic. And he is the current director of the onconephrology service. He's highly published in the field of onconephrology and with COVID-related kidney disease. So we really appreciate his time and his efforts. Thank you so much.
Thank you for the kind introduction, and really want to thank American Society of Onconephrology for inviting me and giving this opportunity to speak. Without any delay, I'll start the presentation. I don't have any disclosure except that everyone should know I'm not a hematologist. I will start with this slide. I think I like this slide because it gives very good overview of different monoclonal protein-associated kidney disease with glomerular disease, including amyloidosis, MIDD, PGNMID. In the proximal tubule, we have light chain proximal tubulopathy, and the topic of discussion today is where we see in distal tubules is Kash nephropathy. Kash nephropathy is produced, I'll briefly touch base about the pathophysiology, that when light chains are produced, they are usually reabsorbed by proximal tubule, and only 30 milligrams per day are excreted approximately. But when they are overproduced, like in multiple myeloma, they are they go beyond the ability of proximal tubule to reabsorb and reach the thick ascending loop of Henle, where they meet Tom Horsfall protein, also known as uromodulin, and they bind with them, forming the dense intratubular cast. Not only it stops here, but these casts are surrounded by giant cell reaction, and they lead to tubular damage and develop interstitial inflammation, which is also part of why we see severe acute kidney injury in addition to the obstruction from the cast. Now, as far as the management is concerned, I'm going to divide the talk in these 4 broad topics: supportive care. We'll talk briefly about anti-myeloma therapy, touch base about stem cell transplant role, and we'll dive deeper into the mechanical approaches. So supportive care, most important thing, first we see patients with myeloma cast nephropathy is to hydration. Concentration of light chain is what determines the precipitation into the proximal into the distal tubule, and the dilution of these light chains can help decrease the acute kidney injury we see in these patients with light chain cast nephropathy. Additionally, myeloma patients also have hypercalcemia, which again, as we know, it can cause further volume depletion and further drive the vicious cycle. So replacement of volume can help break the cycle and also dilute the chains, which can improve the renal outcomes. Now, point I would like to make is IV fluid, aggressive hydration should not be just given based on amount you give, but amount of urine you produce. So it should not be just 3 liters per day, approximately, but it should be gold according to 3 liters of urine output per day, because these patients can have diarrhea, can have excessive sweating. So our goal is to dilute the urine. So urine output should be 3 liters per day, or if they are extreme of body surface area, 2 liters per meter square. Now, as clinicians, we should always be careful when to back off, meaning that patients who have heart failure, persistent oligoanuric AKI, we may have to take a clinical judgment on when to back off on IV fluids. Another important points I'm going to talk about is a bisphosphonate role. So in general, we avoid bisphosphonates with patients with GFR less than 30 mL per minute. However, and it's not uncommon to see hypercalcemia in these patients. So it is by mutual agreement and consensus agreement that it is acceptable to consider palmitoronate. One dose limited by the dose, like approximately 30 milligrams and over 4 hours with a little prolonged infusion, it is acceptable. And that's just mutual agreement, because we have some cases of zoledronate causing acute kidney injury, and we don't have such for palmitoronate. We don't have any original research supporting this opinion, but this is just an opinion that you can consider palmitoronate, because the alternative is denosumab, and denosumab is very expensive and it can cause severe hypocalcemia. However, it's not nephrotoxic as we know of so far. Again, we should always avoid nephrotoxic agents. Now, talking about anti-myeloma therapy. Now, this is loosely defined as doublet, triplet, and quadruplet, and I'm going to use this term for the sake of this talk today. Doublets means bortezomib and dexamethasone-based regimen. Triplet is doublet plus either cytoxan or immunomodulatory drug combined therapy, which is thalidomide, lenalidomide, and quadruplet is triplet plus daratumumab. I'm going to use these terms loosely as defined here. Now, I want to just focus on 2 agents because they are relatively new, and I want to add something with respect to outcomes in patients with light chain cast nephropathy when these agents are used: bortezomib and daratumumab. So bortezomib is a reversible competitive proteasome inhibitor. Proteasome inside the cell is responsible for activation of nuclear factor kappa B. This enters the cell generally when activated and is responsible for formation of many inflammatory molecules and aggregation of cells. And bortezomib inhibits this cycle. Bortezomib, as we know of so far, is not shown to be nephrotoxic. There has been some studies proposing that there is AKI, and a lot of time we look for AKI with bortezomib because AKI is very common in patients with multiple myeloma. However, when we look at prospective randomized control trial, when it is controlled with placebo or controlled in a controlled manner, evaluated in a study, we have not seen bortezomib as responsible for acute kidney injury. It is not renally cleared. And this is a very nice study published in 2013. And these investigators evaluated the novel agents and their association with improvement in renal outcomes. And they divided patients who received, of course, multiple agents, but they were based on thalidomide-based therapy, bortezomib-based therapy, or lenalidomide-based therapy. And the renal outcomes were much better in bortezomib-based therapy compared to thalidomide, followed by lenalidomide-based therapy, suggesting that bortezomib is now considered gold standard therapy for the patients with multiple myeloma and have renal failure, and it's also considered renoprotective chemotherapy. Now, is there any randomized control trial which includes patients with AKI and multiple myeloma and the difference in outcomes? There is one trial that compares doublet versus triplet. Now, this trial was a randomized control trial recently published in 2020, and they compared BD regimen versus CBD regimen, bortezomib dexamethasone versus Cytoxan with bortezomib dexamethasone. It's important to note these patients had acute kidney injury, but they were not on dialysis. So acute kidney injury is not severe in this group of patients. Almost 90 patients in each group, 68-year-old median age, and their median creatinine was 3 through 3.5, thus not severe acute kidney injury, but they were all biopsy-proven cash nephropathy. What was the outcome? No difference in outcomes in renal response at 3 months, 6 months, or 12 months, or even overall survival in this group, whether we used doublet agent or triplet agent. Moreover, patients who received Cytoxan as a triplet agent had higher adverse event, higher serious adverse event, and death compared to the doublet agent, proposing that patients who have not so severe AKI might be okay with doublet agent. However, if we just divide them in the stage 3 AKI patients, the response rate was much better in triplet agents. If we have stage 3 AKI, 23% versus 46%. Not statistically significant, but small number of patients to make a different statistical significant out of it. But the belief is if you have fit patient who can handle triplet therapy and have severe AKI with stage 3 or higher, we should still consider aggressive therapy like triplet or quadruplet agents. However, if they have stage 1, stage 2 AKI and older individuals, doublet therapy might be sufficient as far as this randomized control trial is concerned. Daratumumab, it's a monoclonal antibody against CD38, which is expressed on the myeloma cell. Now, all the trials performed with daratumumab excluded patients with GFR less than 30. So we do not have data about renal outcomes associated with daratumumab in randomized control trial. However, if we were to extrapolate from the data we have, I have used an example of amyloidosis. What I'm trying to show here is when daratumumab is added to the triplet regimen. So this study used daratumumab BCD versus VCD, which is Velcade, Cytoxan, dexamethasone. What I'm trying to point out is how fast and how deep is the hematological response. This is median involved light chain response. And we can see even with cycle 1, by the end of cycle 1, the response is very deep and very fast achieved when we add daratumumab as a 4th agent compared to 3 agents. I'm going to talk about in the next few slides why I'm talking about this, but point is daratumumab can help achieve rapid and deeper hematological response when added to a triplet regimen. Now, International Myeloma Work Group recently in 2023 gave an opinion, not based on randomized controlled trial, but gave an opinion that if you have patients with newly diagnosed multiple myeloma with renal involvement, they recommended daratumumab with VD regimen to begin with, and then assess the light chain response and add thalidomide in it if needed as a quadruplet therapy. Very briefly touching on the stem cell transplant. Stem cell transplant is essential part of patients with multiple myeloma if they are candidate for it. However, we should know that patients with acute kidney injury are usually not considered for transplant at that time. But if they were to remain with chronic kidney disease, and if they were to remain on dialysis and being considered for transplant, we should remember that the melphalan dose needs to be adjusted accordingly, 140 milligram per meter square for GFR less than 30, and 100 to 140 milligram per meter square. If they are on dialysis, this can be divided into 2 also, 70 milligram per meter square the day before and the day off, in 2 different days. Now, I would like to dive a little deeper in extracorporeal light chain removal, because that's when nephrologists also take active role in deciding whether these patients should receive extracorporeal light chain removal when they have severe acute kidney injury, cash nephropathy with multiple myeloma. Before I discuss that, I would like to point out this very nice study published in 2011 in JASN. And what they showed is patients with biopsy-proven cast nephropathy and have severe AKI, their median eGFR is 9 ml per minute. And if these patients were to achieve more than 60% light chain reduction within 21 days after first cycle, before the second cycle, the renal recovery, partial or complete response is 80% or higher, suggesting that it is urgent to reduce the light chains to improve the renal outcomes. Not only that, they also showed light chain response as day 12 compared to day 21. The reason they did day 12 is when day 11 is when you give the last dose of bortezomib on the first cycle. So at the end of the first cycle, and this is at the end of, this will be the end of first cycle. However, this is the end after the last dose of bortezomib of the first cycle. Point is, if we achieve the last light chain reduction by day 12, if you achieve the same degree of light chain reduction by day 21, the renal outcomes are worse compared to achieving the same by day 12. Further suggesting the deeper and faster the reduction in light chains are, better the renal outcomes. So this raises the question, why don't we use a machine to do that in addition to using the anti-myeloma therapy? And particularly because we know the molecular weight of kappa light chain is around 22 kilodalton, lambda light chain is around 45 kilodalton, then why don't we use extracorporeal therapies to remove the light chains, which we can do based on their molecular weight. And this was even shown by Mayo Clinic group in 2011, published in NEJM of 14 patients. And they showed bortezomib was new at that time. So bortezomib, a novel therapy of bortezomib with aggressive plasma exchange, when they performed, the partial renal response or better was 86%. Not a control study. We don't have any control, but still very significantly good renal outcomes, suggesting that maybe plasma exchange should always be combined with bortezomib to achieve such good outcomes. So I would like to point out here the approach proposed, and this part of the diagram is proposing when you should consider kidney biopsy. I would not go into too much details, but the proposal is if the light chain level is below 150 milligrams per deciliter, or if the patients have albuminuria, we should always consider biopsy to confirm the diagnosis. However, if they have more than 150 milligrams per deciliter light chains and do not have albuminuria, we can presume light chain cast nephropathy without doing a biopsy. Now, most important thing I want to point out here is they proposed we should always consider quadruplet therapy is possible, or triplet therapy that includes daratumumab in the regimen, and consider daily plex every day until we achieve light chain reduction of more than 50% from the baseline, or light chain reduction less than 50 milligrams per deciliter of the involved light chain by cycle 1. Very aggressive approach to pursue. And the rationale is the one that was previously published trial, that we need to achieve deep and fast hematological response. Now, what is the data to support this opinion? We can discuss that in detail in the next few slides. So there was initial trial published in 2005 by Canadian Apheresis Group. What they did is they performed a randomized control trial, and patients, the intervention was 5 to 7 plasma exchange therapies over 10 days in the patients who were assigned to intervention. What I would point out in baseline characteristic is the median creatinine and median GFR. These patients have severe AKI, almost 5 milligrams per deciliter serum creatinine with 13 mLs per minute of GFR. Thus, almost 100 patients with severe AKI. And if we look at the outcomes, I'll summarize, only look for the renal outcomes, which is the topic of discussion today. And renal outcomes were not different when they performed this study. Now, what is the rationale they proposed is the molecular weight of light chains. Same rationale that because the low molecular weight, the volume of distribution is very high. 85% of the light chains are located in the extravascular region. So if we perform only 2 hours of plasma exchange, there will be a significant rebound because the total amount removed out of the body is not significant to achieve the improved outcomes. However, what are the limitations of this study? These people were not biopsy-proven cast nephropathy. In addition, the control group had more dexamethasone-containing regimen, which is known to be reducing the light chains faster than prednisone-based regimen. So it can deviate the results of the study. So if we were to use novel regimens of chemotherapy, which is bortezomib and dexamethasone based chemotherapy, and if we only use the patients with biopsy-proven nephropathy, would we have different outcome? That question remained. That took more than a decade to do another trials, which is in 2017 and 2019, we have two different trials, Meyer trial and ULIGHT trial. This is the Meyer trial where they performed almost 100 patients divided in half and half, high flux dialyzer versus 5 hours of high cutoff dialysis, 8 sessions in 10 days. All patients received bortezomib and dexamethasone based regimen. Now, interestingly, the outcomes were renal outcomes were not different at 3 months, but they were better at 6 months and 12 months, to surprise. So outcomes and studies being performed for first 10 days and outcomes are not different at 3 months, but they are better at 6 and 12 months. Now, if we were to move it to ULIGHT trial was again UK and Germany based, almost 90 patients, half and half division. They perform very aggressive high cutoff dialysis. They perform 8 hours of high cutoff dialysis for 10 days, followed by 3 times every day, followed by 3 times a week for another 10 days, and followed by 6 hours a day, 3 times a week for rest of the 3 months, meaning that all 3 months patients are receiving high cutoff dialysis here. Outcomes, renal outcomes at 3 months, not different, but they have higher incidence of pneumonia and higher incidence of death, 37% versus 19%. Thus, it was suggestive to be harmful to perform these interventions. But again, we have to discuss the limitations of these trials. Concern is high cutoff dialysis can remove albumin. And when we perform aggressive high cutoff dialysis and do not replace with albumin, loss of albumin can cause hypertension, can cause further AKI. And these patients receive albumin replacement only if the serum albumin is less than 2.5 gram per deciliter. Again, patients with high cutoff dialysis intervention had higher infection and hypercalcemia incidence. So they were relatively sicker when randomized. And ULIGHT trial, they used very aggressive high cutoff dialysis, and that can remove light chains, which can compromise your immunity, can cause infection, interrupt the chemotherapy, further increasing mortality. And they did not use any prophylactic antibiotics. So if we were to use prophylactic albumin, prophylactic antibiotics, and use a larger number of patients, could we see better outcomes? We don't know. We need more data. So here I would summarize the treatment or my talk so far, that aggressive hydration is first and most important thing, with target urine output of almost 3 liters a day. A single agent palmitonate 30 milligrams over 4 hours possibly can be considered even if in the setting of acute kidney injury with light chain nephropathy and multiple myeloma. Bortezomib is a renoprotective and gold standard of chemotherapy at this time. Rapid reduction of light chains and is associated and directly related to rapid renal recovery, with goal being more than 60% reduction in light chains by day 21. Doublet therapy can be acceptable in patients with stage 1 and stage 2 mild AKI. However, triplet and possibly quadruplet should be preferred among the patients with severe AKI with light chain nephropathy. And addition of daratumumab should be considered because it can hasten the response of the triplet therapy to achieve the rapid reduction of light chains, which is not standard at this time. Currently, daratumumab is considered standard for patients with high-risk multiple myeloma, which is if you have a mutation like translocation of 14 to 18. If you have high-risk myeloma, then they consider upfront daratumumab with VCD kind of therapy. So if we were to summarize the extracorporeal light chain removal, these are 3 different opinions published in this year. And this is very interesting because all published in 2023. Plaque should be performed daily until light chains are reduced, less than 150 milligram per deciliter or more than 60% light chain reduction is achieved, published by Mayo Clinic Group, versus International Myeloma Work Group in Lancet Oncology. They suggested that they would mention in the gray zone, meaning that it's a grade C recommendation, that it can be considered, it may improve based on the data we have, versus an opinion published in Kidney 360 and a commentary which described pros and cons and the moderators at the end summarized that considering patients' burden, cost, and potential risk of dialysis, we have clear indication against use of high cutoff dialysis in AKI patients who do not require kidney replacement therapy. However, all those who are on dialysis, question remains whether we should add a membrane with a limited cost, whether it can improve the renal outcomes in these patients. I would like to summarize this with this slide. I'm a big physics enthusiast, and I take this as an I take physics sometimes as my reference. This is a nuclear fusion power plant. It's going to be the largest man-made machine till date once it's completed, and it's made in France. It's being made in France, almost 14 billion budget US dollars. And you can see the countries involved in making, countries that may not get along, other reasons, but they do work together to move science forward. And that's the only way for us to move science forward, to collaborate internationally and combine all the data and brains we have to move science forward. And that's what we need in this kind of situation. When we don't have enough data, we need international collaboration to move forward. And that's where I will conclude my presentation. Sorry, I'm not able to hear you clearly. I'm not sure if it's my microphone.
Sorry. No,
Okay.
it's me. Sorry. Thank you so much. That was a great presentation. Couple of questions. So one question is, does it make any difference what kind of IV fluids you use?
Good question. I did not go too much details in it. All are not based on, of course, randomized controlled trial, but the goal is to dilute urine and achieve the sufficient urine output. So we will have to decide clinically if patient is hyponatremic, if they are volume depleted, to use half hypotonic IV fluid, like half normal saline or normal saline if they are hypotensive, if they have hypercalcemia, if they need more volume expansion, then you will need isotonic fluid. In general, if you don't have any, half NS might be sufficient.
Great. And when do you consider the use of hemodialysis in patients with hypercalcemia associated with myeloma? Is there necessarily a lab cutoff or altered mental status or anything like that?
Very good question. Thank you for asking. We recently had a patient with serum calcium of 20, and Onconephrology decided to urgently dialyze the patient with symptoms. Interestingly, by the time dialysis orders are put in and patient receives dialysis, in 6 hours, serum calcium went down from 20 to 14. My point is, these patients are very volume depleted, and if they are making urine, first line of therapy is IV fluid, second is IV fluid, third is IV fluid. I mean, they rapidly correct the serum calcium. If they are anuric and we are worried about it, that's why I think I wanted to point out about pamidronate. It works rapidly, it is very efficacious, and it is acceptable because you will have very limited option if we do not use pamidronate. Now, if patient is symptomatic, we do not have pamidronate, they cannot receive volume, I would say take clinical judgment based on symptoms if they need dialysis.
Perfect. And then do you routinely prescribe any sort of prophylactic therapy to patients started on triple therapy? So like Septrin or Bactrim, levofloxacin, acyclovir, anything like that?
Yeah, I think the recommendation is to consider levofloxacin. I will have to check with our oncology department because sometimes they do not have renal failure and I'm not involved in the case. So I'm not sure what is their policy currently, but the recommendation, especially when you consider plasmapheresis, is the recommendation to consider levofloxacin or similar prophylactic antibiotic to prevent pneumonia, infection, and interruption to chemotherapy that could be possible secondary to the same.
Perfect. Well, thank you so much to our speakers and to our audience members. I'll ask our Iranian colleagues, I'm not sure if they want to have any closing remarks, but I think this was a really wonderful presentation. Dr. Savage, did you want to? Yeah.
Thank you very much for all of the friends and colleagues and professors for this program, Professor Rashidi, Dr. Karam, Dr. Shah, and you for nice managing of the program. I want to announce the next program for the Onconephrology is 17th of October. That will be future. We'll share the poster and data with our colleagues. And if because of some barriers for connection to the internet, is it possible for my colleagues that who could not connect? We have a link that they could find the program and join it or not? Is it possible that we have it later?
Yes, we can make a recording for you. That should be okay. I'll double check with the ISN.
Thank you very much.
All right, you guys have a good rest of your evening and rest of your day, everyone. You guys have a good day, all right?
Thank you.
Thank you very much. Thank you. Thank you. Thank you.